CSE is something like combined spinal epidural technique. Does intentional injection of drug into a subarachnoid space and placement of catheter in the epidural space as a part of same procedure. Here it combines the features of spinal blockade and epidural blockade. In spinal, we will have a rapid onset profound blockade and we give a low dose. In epidural, it is titratable and the ability to prolong the effect indefinitely can be seen. So main applications where we use this in urology surgeries, labor analgesias, and which is converting into LSES, and ortho trauma surgeries, and in some pediatric surgeries also. Techniques depending on the needle insertion and also depending on the dose how we give, either it's a low dose or full dose. Earlier it was like a single pass where the epidural injection is performed in same needle and it is advanced into subarachnoid space. It had so many complications. Then it came a needle to needle technique. Here we identify epidural space, then we pass a spinal needle in and through the epidural needle beyond its tip, then we puncture the after administering drug in the subarachnoid space, we remove the spinal needle and give the epidural catheter. So the main problem through needle to needle technique is failure of a spinal component can occur. Catheter migration into the dura and friction and the damage, friction of the catheters and damage to the needles, spinal needles can occur. Some modifications like back eyes in the epidural needle was introduced. This allowed spinal needle to go straight without a friction, and there was also easy insertion of the epidural catheters. Then came the lock-on-to techniques where the spinal needle gets locked onto the epidural needles. This is for the stabilization of spinal needle, so it does not get displaced while giving injections. Other than that, that is a separate needles technique where different needles are inserted, different needles for subarachnoid and epidural catheter placement given, either at the same interspace or in a different interspaces, like epidural up and the spinal below. Here the problems what we face is shearing of catheters and a saddle block if the spinal is performed before the epidural. Then came the double barrel technique. Here we have double barrel, which is a parallel needle, one for the spinal, the other for the epidural. Then came the dual catheter technique where two catheters are inserted, one into the spinal and the other into epidural. But the problem of infection and entanglement of the catheters is seen. Then coming to the other technique about the drugs, where we give a low or a sequential sequential doses or a full dose of CSF, full dose CSE. Sequential is here we give a low dose subarachnoid followed by topping up with the epidural drugs 15 to 20 minutes later. This reduces the hypotension, like sudden onset of hypotension, and it is better for the cardiac cases because it gives a better hemodynamic stability. A main disadvantage is it takes time and it is unsuitable if it is an emergency or urgent surgery, and it is restricted only to the lowest levels needed, and sometimes a minimal blockade can be seen. In full doses, we give full complete doses, and we could see a hemodynamic compromise here, and there is no control over the block height can be seen. Main complications of CSE is, as I said, there can be either failure of a spinal component or epidural component, migration of catheter, error in drugs, like the drug what we loaded for epidural can ending up in spinal, and it can result in total spinal damage to the spinal needles or the epidural catheters, and as hematoma, cauda equina syndrome, infections, meningitis, paresthesia can occur. There is a word on EVE, which is epidural volume extension. This epidural volume, this can influence the anesthetic level and the quality of subarachnoid block. The main mechanism here is compression effect on the subarachnoid space that promotes the cephalad spread of the local anesthesia when it is given in epidural. So this is actually time dependent. Yes, that's all.
Very good. So anyone in this audience who have not seen a combined spinal epidural or done a combined spinal epidural? Any of you?
Yes, sir. We do. Yes,
Huh?
yes, sir.
All of you?
Yes.
Yes, sir.
Okay. So none of you are new to this technique, isn't it? Even the juniors have all seen this technique. So this technique was actually introduced by an anesthetist who was a OG anesthesiologist. Okay, so you know OGians are very restless people. They can't wait. If you do pure epidural technique, you cannot have the effect of the technique coming on immediately. You have to wait for quite some time for the full effect to come on, which invariably the physicians can't wait, especially if it is going to be a cesarean. They want the anesthesia to be as rapid as possible. And so to satisfy them, the first technique of combined spinal epidural was done in two different levels. What he did was he first passed an epidural catheter but did not give any drug in the L3, L4 space. Then L4, L5 space, he introduced the spinal needle, he gave a subarachnoid block and made the patient supine and started the surgery because the onset was immediate. And whenever there is a need for prolongation of the duration or if the level is inadequate, we used to give a top of dose through the epidural catheter and achieve the level required. This is how the whole concept of combined spinal epidural was introduced as a two-level technique. Later on, to avoid the unnecessary pricking of the patient in two levels and trying to use the needles, they combined it to single level. And whatever commercial sets that you are all now seeing are using the single level or a single puncture needle through needle sets are only available commercially, isn't it? So in that what you do, you first identify the epidural space either by loss of resistance or using saline. Once you have reached the loss of resistance and you are sure that you are in the epidural space, then you introduce the longer, thinner spinal needle through the same toothy needle and puncture the dura, see the flow of CSF, attach your hyperbaric local anesthetic syringe to that spinal needle, inject the required volume or lesser volume, however you decide, then remove the spinal needle out of the needle, then introduce the catheter, make sure that it is there 3 to 4 centimeters, and then remove the the epidural needle also and fix the catheter and proceed with the surgery. Now the drawback in this technique is because you are giving the hyperbaric solution, it gets fixed up and the patient's part of the body becomes anesthetized. By the time you thread the catheter and other things, the effect has come on. So sometimes patient may be, if you are doing it in the sitting position, patient finds it odd to sit in a paralyzed leg in the sitting position. They may sway and all that. Or if you are doing it in the lateral position, it may become settled in one half, the other half may become patchy. All these problems are there. So what exactly somebody did for modification to avoid this problem is introducing the spinal needle parallel to the introduction of the toothy needle or the epidural needle in the same space. Instead of it passing through the epidural needle, somebody thought of a new method where they can first identify the epidural space after giving adequate local anesthesia to the skin and the subcutaneous tissue and the ligaments. Identify the epidural space, even thread the epidural catheter into the space, and after noting down the length or the distance up to which it has gone in, introduce a thin spinal needle 25 gauge or 27 gauge parallel to the epidural needle and go and puncture the subarachnoid space and then inject the drug and remove both the needles together. So that is what is called the modified technique, which is written in one of the articles, and then it was published, and it is now still not come into the textbooks, but it is considered to have more advantages than the regular needle through needle technique. And that is what I just thought I'll ask as a question as a modified spinal. And all these modifications, all of you know, have been done through the various methods as you described. So we'll just go through what is being happening here. So with the patient for this modified combined spinal epidural may be in the sitting or in the lateral decubitus position. First, you identify the epidural space with loss of air with a regular needle, or in the same space adjacent to the epidural needle, you insert the other needle and the correct position confirmed by free flow of cerebrospinal fluid, and then you put the stillet back into that to prevent the loss of CSF. Then you insert the epidural catheter uh, uh, into the through the epidural needle. You even give a test dose to make sure that it is working. And after 3 minutes, that the epidural catheter is either intravascular nor subarachnoid. To give the required quantity of bupivacaine heavy injected through the spinal needle, which is introduced on the side of the epidural needle, and then the needle is removed. And the epidural catheter, which has already been introduced into that, will be fixed and then patient made to lie down. And given top up only beyond 3 hours of surgery. So the two advantages you will find here are you are able to introduce the catheter, you are able to give a test dose and make sure that the epidural catheter is in the proper place, and then you are giving the subarachnoid block so that the patient does not have to be sitting or lying down with the subarachnoid block having already been established. That is the main advantage of this technique. So these advantages are since both the needles are inserted in the same space and the site of puncture has already been infiltrated with the local anesthetic only once it has been done. So two space techniques requires two level infiltration. That is avoided. And epidural test dose has been administered here. So you know that patient's epidural catheter location is normal, and this is not possible with the other CSC techniques except with the Eldon needle or a screwless double space technique. So they have done this because the test dose containing adrenaline cannot go into the subarachnoid space if you have not punctured the subarachnoid space before passing the catheter in. And the third advantage is the epidural catheter may be advanced without haste. So in elective surgeries, you don't have to rush that having given the subarachnoid block, you don't have to rush pushing the catheter inside. And unlike in the needle through needle technique, where fear of spinal anesthetic getting fixed may lead to placing the epidural catheter in a hurry, which is not there. And if the epidural catheter is passed with the spinal needle in situ, the possibility of entering the subarachnoid space. The catheter may migrate into the subarachnoid space if it is introduced through the needle through needle technique. And spinal anesthesia is administered last after you introduce the catheter. Positioning of the patient to supine and the resuscitation if there is any complication can be immediately started. Whereas if you have given the subarachnoid block first and there is a hypotension, then immediately you have to make the patient lie down if you are doing it in the sitting position, and rest fluids, give ephedrine and all these things can be avoided. And custom-made CSC cuts is no cost here. Whereas here you can use your regular tuning needle with a catheter and your small gauge spinal needle, which is not going to be that much costlier also. But the disadvantages, any technique has got its own advantage and disadvantage. The disadvantages are there is additional time required to identify the subarachnoid space when the spinal needle is the side of the epidural needle. So learners or brushers may find it more difficult to do this. And inexperienced anesthesiologists trying to locate the subarachnoid space may displace the epidural needle, and which require insertion of the epidural catheter to re-identify the epidural space. And insertion time may be little longer than the needle through needle technique, and the epidural catheter may be displaced when the spinal needle is being withdrawn. So When you remove both the needles, you may sometimes remove the catheter also. So modified CSC analgesia is modifications done by individual practitioners to improve the safety of the technique, and it is not a standard one. So all the changes that have happened in combined spinal epidural has been the innovative thinking of the practitioners. So it is not done anything standardized or anything like that. So if you come up with some new idea, you can introduce your own technique also and call it as a modified CSU. Okay. Right.